Dr. Shikha. Dr. Shikha, ma'am, please join us on stage. Ma'am.
So, good afternoon. You heard about the miracles with, drugs. Cancer, as you know, is a multidisciplinary treatment, and many years ago, radiation was always considered as a palliative method of treatment, and whenever nothing could be done in cancer, the patient was referred to radiation, and it was supposed that radiation सब कुछ जला देगा. But over the years, you will listen to the lecture now, radiation has done a lot of changes in the management of cancer, and it has led to organ preservation in a big way, and the morbidity has really gone down. So modern radiation, which we are practicing today, will be presented by Dr. Deep.
Thank you, sir. Good evening, everyone. It's a privilege for me to be speaking in front both of my seniors from the department. Curing cancer no longer means losing organs. Yes, this is one of the biggest shifts in modern oncology. Earlier, cure meant sacrifice. You will see a lot of ectomies being done for cancer, and survival actually came at a functional cost. Today, there is cure with preservation. Organ preservation and function is actually now a treatment endpoint for specific tumor sites for specific selection criteria. And radiotherapy sits at the heart of this shift. What is organ preservation? To achieve oncologic control while maintaining structure and function of the involved organ. Radiation therapy techniques have drastically improved over the last 30 years. It is not just radiotherapy, it is now precision medicine, because we are able to see better with the help of newer imaging and better imaging like PET and MRI. So our radiation margins have become tighter. We are able to target better with image-guided radiotherapy, intensity modulated and motion management, so the side effects are less. And we are treating smarter because the number of sessions of radiotherapy are actually going down with hypofractionation stereotactic radiotherapy. So let me walk you through some examples of organ preservation. First, larynx and hypopharynx. For early stage tumors, there's radiation alone. And for advanced stage T3 and T4A select cases with a functional larynx, concurrent chemotherapy and radiotherapy is the treatment of choice. The oncological outcomes are comparable to surgery, and patient avoids a stoma. For urinary bladder, so the treatment of choice is cystectomy, but then there is organ preservation approach, which has three components: maximal TURBT, which is the resection of the bladder tissue, chemotherapy and radiotherapy. This is known as tri-modality therapy. Again, specific indications for bladder preservation, and it is also can be used for patients who are unfit and refusing for surgery. See, the patient is avoiding a urobag. Anal canal, the earliest standard of treatment was APRs with permanent colostomies and loss of sphincter function. Now, definitive CTRT is the treatment of choice. Surgery is actually removed from the first line treatment. Even in rectal cancers, there's an evolving role of non-operative management, because after radiotherapy, if the patient has complete clinical response, there is an option of observation, and more data is coming up in this field. And of course, with immunotherapy, there is even some patients can avoid radiation and surgery. So with this, we are avoiding a stoma bag. So you see, the quality of life of the patient is maintained, the image is maintained. Now the biggest shift has happened in breast cancer. Earlier, breast cancer meant removal of the chest, mastectomies. Now there is breast conserving surgery in which only the lump is removed, and then we add radiotherapy. So the combination of BCS with radiotherapy is equivalent to mastectomy. That means patient gets to preserve the image with a better quality of life. Esophagus. So the treatment of choice is neoadjuvant chemotherapy, and then the patient goes for surgery. However, definitive CTRT can be offered for patients who are unfit for surgery. In fact, for cervical esophagus and upper thoracic esophagus, it is the treatment of choice and surgery is not done. Similarly, in cases like in rectum, if patient has had a complete clinical response, there is an option of follow-up and more data is coming up in this way. Prostate, the age-old debate between surgeons and radiation oncologists, which is better. So for localized prostate cancer, whether it's low, intermediate, high risk, radiation plays a key role. And in high-risk cases, it is actually preferred. Equivalent cancer control to surgery. With the advent of stereotactic radiotherapy, the number of sessions gone down. So from initial 40 sessions to 28 sessions to 20 sessions, now in select cases, you can actually treat in 5 sessions and even maybe lower. And that has led to more convenience and compliance. So what is this stereotactic radiotherapy? So it is high-dose radiation, surgical accuracy. So imagine for cases of cancer, radiation behaves like a non-invasive surgery. And there are multiple examples in brain tumors, benign cases, metastasis, malignant cases. For example, in AVMs, in vestibular schwannomas, in brain metastasis. You see, this is a classical case of a single brain metastasis treated with radiation and the met has disappeared. You don't need to go under the knife every time. For lung metastasis, also similarly, you can see one case scenario in a peripheral lung metastasis after SBRT, the lesion has vanished. Similarly, for liver metastasis, HCC, portal vein thrombus, you name it, radiation has a role, and stereotactic radiotherapy has actually changed the game in this case. So organs move, and so does the tumor. So how are we able to manage this motion? We can either restrict the movement with the help of abdominal compression during the radiation planning. There is internal target volume approach in which actually the CT scan is divided into multiple phases, and we draw our radiation volume in all the phases so that the tumor is moving and the target is also being treated. Or we can gate the treatment. By that I mean we can actually choose which phase of respiration we want to treat in. For example, end expiration, so the beam will only be on when the patient is exhaling. And there is also deep inspiratory breath hold, where patient is holding his or her breath and being treated, which actually is a classic case in which we want to see the heart. So organ sparing is incomplete without the mention of interstitial brachytherapy, within, not externally. The maximum dose is in the tumor and the nodes are spared. For example, in head and neck carcinomas, in breast cancer, in sarcomas, recurrent cancer, even cancer. So you see, preservation from external to internal radiotherapy has multiple steps. With this, I would like to introduce our Department of Radiation Oncology. We have 2 state-of-the-art machines. One is true STS with IR, millimeters. So you can actually treat tumors with accuracy finer than the grain of rice. Non-coplanar RF radiation can be delivered from multiple angles. There is real-time image guidance in position is correct before treatment. We can actually treat multiple lesions simultaneously, which means a single isocenter setup. Advanced motion management which tracks the tumor. So there's another radiation machine we have in the department, is called therapy. This actually looks like a radiation therapy machine. So how I'm equating it, that CT scan image size and tomotherapy treats patients. So it actually conforms to the size of radiation to slice rather than the old tumor. And the machine, the radiation accelerator moves out. This makes long and legs. The beam is laser surgery, tomotherapy is precision. We have the luxury of both machines. Also, highly expensive part of radiation oncology with the latest afterload microscope HBM192. Submeter accuracy, it is CT and compatible, it is multi-therapy, the abdominal, all